see a bunch of people here early in the morning. I saw some people get here around 7:20. I guess they wanted to get to the buffet line first. Is that what happened? Those people? Well, I'm Eric Koltoff. I'm thrilled to see so many people here this morning to take advantage of the first of several proactive PayServ seminars on the Affordable Care Act. It's a good opportunity to get ahead of the curve, which is what we've been working to do for over a year now. I am the Vice President of Sales for PayServ. I'm joined here by our Executive Vice President, Heather Markle, as well as Andrea and Brent from our sales team, and by my friend Scott Pearson from PMG Agency and his team, which we'll introduce a little bit later. We've been working, as I said, ahead of the curve for over a year now to try to help our clients get educated, help ourselves get educated about the ACA, so that we can all be prepared for the changes that are coming January 1st of 2014. And actually, open enrollment starts in the fall, which is right around the corner. So it's good that you're here and you're taking advantage of this seminar that we're putting on. The big questions that everybody has: what will it cost me? That's probably the biggest question. But do I have to provide benefits? I'm under 50 employees. Do I have to provide benefits? And can I provide benefits because I want to take care of my employees and save money? Well, to that end, PayServ has created the ACA Full-Time Equivalency Trending Report. This is a report that will help you learn your liabilities and your opportunities with the ACA as far as your employee count and your wages, and that is why we have Scott and his team here to talk about that. The reason why we're able to create this report is because we are a payroll vendor and we have that data as we process your payroll. So your payroll vendor is a very important strategic partner here, because we can provide the information to your insurance partner to help you make the right choices for your company. Many of you know Todd Saylor. He's the founder and president of PayServ. He grew up here. He founded PayServ here many years ago. And he takes his responsibility to his clients and to the people of Indiana very, very personally. He holds it as the most important thing in his mind, is taking care of other people. His commitment to customer service excellence is what led us to put together these seminars so that we could help reduce the stress for our clients and for the people that want to work with us in understanding and getting educated about the ACA. To that end, I do want to introduce Scott. I'll bring him up in a second here. Scott is a partner and an owner at PMG Agency. They're based in Fort Wayne. They've been here for over a decade, I think 14 or 15 years now. They have 4 locations in the area. Scott has been a friend and a partner of PayServ for many years. He treats our clients very well. He treats us very well. I have a lot of trust in him and the agency that he works with. He's very educated with the ACA. He's what we refer to as an ACA expert. He has Scott, Mike, Chris, Tom, and Kayla, who he'll introduce as well with him. So we have a full team of people here to help you. We're all here to help you make the best choices for your company. There are a lot of options. It's not as simple as what you might have read in the paper, and it also is not as complicated as you might have read in the paper. You just have to have the right information. That's what PayServ and PMG are here to do. During the course of the presentation, which will be up on this wall over here, there'll be time for questions and answers throughout, so you don't have to save them till the end. And then when the presentation's over, there'll be time to work one-on-one with everybody from PayServ and PMG if you have some questions you want to talk about personally with them. There'll also be a door prize, or actually 2 door prizes, so you have a good chance of winning something. And I look forward to introducing myself to you in person as well. So I'm going to bring up Scott here, and he'll lead us into the presentation.
Thank you. And one of the reasons that we're doing this is we're getting a lot of calls, a lot of emails, just a lot of inquiries, and some of these questions are being brought up consistently. I want to offer health insurance to my managers. I have employees in multiple states. My company's too small to offer health insurance. And all these questions are being directed to how is healthcare reform going to affect all these questions that come up. And the one certainty about healthcare reform right now is there's a lot of uncertainty. There's still a lot of regulations, there's still a lot of rules and different things like that that are still out there that people don't know if they've been passed or how they're going to affect, etc. Well, we've been working on this with our partners at Anthem and United Healthcare and some of their companies for several months now. And just kind of give you a little background about PMG, as Eric mentioned. Tom established, my partner Tom Julius, he established the agency in 1999. So we've been around doing individual and group health for quite some time. We have many affiliations that we're with. We sit on the advisory board of several of the insurance companies. We have Mike, who's a registered health underwriter. We have certified healthcare reform classes that we've taken. So we have a lot of information in regards to the healthcare reform and things. And so with that, I'd like to kind of introduce the team. And Mike Suhaney is going to be doing the segment today, the first portion of the seminar. On the laws and actually the regulations and some of the reforms that's taken place. So it kind of gives you an idea of the time frame and time standards of different laws that's been changed and how we'll segue into that for the individual and group side. Chris Cotton, who is at our Syracuse office. I should mention Mike is in our Warsaw office. As Eric mentioned, we have 4 offices now in Warsaw, Greenfield, Syracuse, and then our home office in Fort Wayne. And Mike runs our Warsaw office, Chris runs our Syracuse office, and then Tom Julius, which most of you know, who's the president and partner, does a lot of our group insurance. And then Kayla Garza, who's been very instrumental in putting the seminars together for us, the PowerPoint presentations, doing a lot of the research to put the stuff together and everything. She works a lot on our marketing, our SEO programs, and different things like that. So that's the team. But basically what we're going to do today, we're going to break this down into 3 different segments for the seminar, like I mentioned before. We're going to go through the laws and the regulations and the reform and how it came about, and Mike's going to go and explain about that. And then we're going to go into the individual side of it, which is where the market is heading, individual health insurance, and how that affects in different exchanges, et cetera. And then Tom will follow up on the 3rd segment with the group health insurance portion of it and talk about how it's going to affect a lot of you here in this room. And then as far as like questions and things, if you want to just ask questions as we're going along, I think that way it's fresh and we can keep it in perspective right there for each segment and stuff. And then we'll close and then we'll go through any specific questions, things towards the end. So with that, I'll go ahead and bring Mike up, and then he can start on the.
So my name's Michael Suhaney, as Scott mentioned, and I'm in our office in Warsaw. I've been in health insurance for over 13 years now. Worked in an independent agency, worked as a captive agent for Anthem Blue Cross Blue Shield, and now just focusing in on just healthcare with the rest of the guys at PMG. Kayla will start there. So the Patient Protection and Affordable Care Act was passed on March 23rd, 2010. A week later, the Healthcare and Education Reconciliation Act was passed. That was March 30th of 2010. And together, those are the affordable. Two amend several major laws. In fact, they really amend almost every law that has to do with employees and the employer-employee relationship and healthcare, except COBRA. COBRA is the one law that the Affordable Care Act did not amend. There are several regulation and rulemaking bodies that are involved in the whole process. Health and Human Services, the Department of Labor, the Internal Revenue Service, and in every state, their legislature and their departments of insurance. So it's just a huge undertaking as all of those regulatory and rulemaking bodies work through the legislation, work through how it amends all of the other pieces of legislation, and we are still seeing on a weekly basis major rulemaking decisions come out, and it's in some ways a very exciting time, but in some ways it's also a very uncertain time. Wanted to give you an idea of just some of the changes that have already happened. We're not going to go through all of these points, but if you see a point on the slideshow that I don't touch on and you have questions about that, feel free to ask them or to catch me later. There were some changes that happened right away in 2010. The one that you might be most familiar with is the dependent coverage age extension, so that you could keep a dependent on your health insurance plan to age 26. And really, there's no requirement that they truly be a dependent from tax purposes, that they be in school or anything like that. Basically, they have to be yours, and you want to claim them, okay? And you could keep them on your health insurance plan. Another major change that most people wouldn't be aware of is that in 2010 there was a prohibition for pre-existing condition exclusions up to age 19. So if a insurance company was insuring someone under the age of 19, they couldn't deny them coverage, couldn't exclude pre-existing conditions. And something interesting happened in the individual market, especially then. I mean, Chris, what did we find then? All the insurance companies did when they could no longer turn down someone under the age of 19.
They quit offering coverage.
They did. I mean, so in the individual market, to get insurance for someone under the age of 19, you actually had to insure a parent as well. Whereas in time past, we could write child-only policies. Now we no longer could. We had to insure a parent in order to insure a child on a plan. So one of those unintended consequences of the law that is supposed to extend coverage actually has, for the last 3 years, resulted in fewer people being able to get coverage. Changes in 2011, the tax penalty for taking money out of your health savings account and not using it for a qualified medical expense, that tax penalty went up. And you were no longer able to actually reimburse yourself out of your health savings account for over-the-counter medications unless you had a prescription from a doctor. And then in 2011, medical loss ratio regulations came into play. And all of the carriers were looking at their loss ratios and adjusting commissions. More tumult in the industry. So, and I don't know if you were aware of that. Most insurance companies operated very close to those numbers anyway. But if you think about that, that insurance premium that you're paying every month, the insurance companies are taking 80 to 85% of that and turning that right around, sending it right out the door to pay for health care. And one of the features of the legislation was to just make that actually a regulation that the companies had to follow. In 2012, one of the changes is insurance companies were required to send out a 4-page summary of your health benefits. And to give you an idea of what happens, the more the government gets involved in something, that 4-page summary of health plan benefits actually turned into 4 pages, double side, both side, and a 4-page glossary. So what the law mandated to be, a 4-page summary became a 12-page document that insurance companies had to send out to everybody they were insuring. And then for tax year 2012, many companies were required to actually report on the employee's W-2 what the total cost of their health care coverage was. Changes that came along and are coming along this year, a big one is that employers are going to be required to notify their employees of the availability of the exchanges that are coming next year. Whether or not the employer has a group health plan or not. If the employer is subject to the Fair Labor Standards Act, the employer has notice requirements, and by October 1st has to notify their employees of the availability of the exchanges. There's a decrease in the deductibility of medical expenses. That's another change coming. But then the big changes are happening effective January 1st. And the biggest change is going to be in the fare premiums. So now on a group health insurance plan, on an individual plan, people can be rated based on their sex, male and female. And they can be rated based on their age as the insurance companies deem appropriately, as pricing their product for particular ages. And the cost of the insurance can be adjusted based on medical conditions. And in the individual market, insurance companies can decline to offer coverage at all. So that's kind of the world we've been operating in for years. Well, that all changes in 2014. Fair premiums means that an insurance company can only vary the rate based on age on a 3-to-1 ratio. So a 21-year-old and a 64-year-old, the 64-year-old can only be paying 3 times the premium of that 21-year-old. So whereas we've seen 7 or 8 times difference between the youngest and the oldest, now that's going to be a 3-to-1 ratio. And what's going to happen? The insurance companies are going to have to still price their products appropriately for the 64-year-old. So it doesn't go like this, it goes like this. And you're going to see coverage for younger people become very much more expensive. The insurance companies can vary the rate based on your residence, realizing that health care is more expensive in different areas of the country and even the individual state, and they can rate you for tobacco use. So gone is that ability to charge males and females different rates. That's going to increase the rates for young males. And it's going to have potentially decrease rates for older men. Because what we see is that women are more expensive to insure in younger ages. Men, probably because of all those years of neglect, become more expensive to insure at the older ages. So that's just going to have a tremendous impact on the rates out there in the market, especially then in the individual market, because no one can be declined for coverage. So you have people out there without insurance incurring catastrophic medical claims now. They will be guaranteed to be able to come into the market, and the insurance companies will have to insure them, can't charge them any different rate, and will experience those losses. There will be an individual and small group exchange, and you may have heard about that. I mean, the state of Indiana has defaulted to the federal government to set up the exchange for the state of Indiana. It'll be a place where you can go, shop for, and find your coverage. And going through that federal exchange is where you can receive your tax credits or premium subsidies if you fall below 400% of the federal poverty level. There's the individual mandate. You're going to have to report to the government. Do you have health insurance? And if so, where? And if not, why not? And incur a penalty tax because you do not have it. There's the pay or play tax for large groups. If a business has more than 50 full-time equivalent employees, the federal government says you have to offer affordable health insurance coverage to your employees, or you're going to pay a penalty. So there's a penalty if you don't offer coverage, and there's a penalty if you offer coverage, but it doesn't meet the standard of affordability. And that standard basically is that someone should not have to pay more than 9.5% of their household income to go out and purchase health insurance. And then just to give you an idea of some of the things that can be hidden in this legislation, clinical trial coverage. Today, if you want to partake in a clinical trial, somebody has to pay all of your expenses associated with that clinical trial. Well, the legislation now says that if the federal government is paying anything toward the cost of that clinical trial, then your health insurance has to pick up all of the medical expenses other than simply the experimental device or procedure that you're being treated with. But all of the surrounding medical care to that, the federal government says your insurance company has to pick that up. Just another way to shift the cost to the insurance companies, but then we all know that cost then gets passed through to the people who purchase the insurance in the form of their premium. All of the plans as of January 1 will have to cover essential health benefits. There we go. If you have a good comprehensive major medical plan, you probably already have coverage for all of these items. The one item that is new to the individual market is that maternity coverage will be just built in to each policy, and that's going to drive premiums up in the individual market. The essential health benefits are going to be covered at one of 4 levels. And this is, you might hear people talk about the metal levels, bronze, silver, gold, platinum, which represent 60%, 70%, 80%, or 90% of actuarial value. So you go, what in the world is actuarial value? Well, imagine that you have 100,000 people insured, and the expected level of claims that those people will have is $1 million. So a plan that is going to pay $600,000 of that $1 million would have a 60% actuarial value, and so on up the line. Now, this is something else that's going to drive premiums. I mean, how many of you have a high deductible health insurance plan that's compatible with an HSA? And maybe you have, what are some of the deductibles you have? I mean, you can have them as high as, in the $11,000 range. We see them lower than that. But, you have that high deductible health plan, and it just makes perfect sense. You've got this premium that you're paying to the insurance company for, coverage for anything beyond that $11,000. You take that premium savings then and put that in your health savings account, and the money accumulates there. It's there if you need it for those claims. It just makes such perfect sense, but it's not going to meet the 60% actuarial value. So you're going to see insurance companies come along and say, you know what? We have to lower your deductible on your health savings account plan. In fact, groups, they can only have a maximum of a $2,000 individual, $4,000 family deductible on health savings accounts under healthcare reform. What's that going to do? It's going to drive up premiums. So, and then all that happens to you unless your health insurance plan has grandfathered status. And what does that mean? That means your health insurance plan was in place before March 23rd of 2010, and you have not made any prohibited changes in that plan. You haven't changed your deductible. You haven't changed the cost sharing in copays beyond a certain permissible range. So you've had your health insurance plan unchanged basically since March 23rd, 2010. So that gives your plan grandfathered status. That allows you to avoid some of the mandates under healthcare reform and avoid the administrative and healthcare costs that go along with them. There are certain mandates that aren't avoidable, even if your plan is grandfathered, but those are not the ones that typically are going to drive premium up the way the mandated changes on non-grandfathered plans are going to come about. Okay, well, I'll be around, happy to answer any questions you have, and I'll just turn things back over to Scott.
What I'd like to do is touch on the individual portion of it and just provide you with a little history and background. Back in the 1940s, there was no such thing as group health insurance. It wasn't available. Everybody carried their own individual Blue Cross and Blue Shield plan. And when the war came in World War II, there was a shortage of workers, so they started bringing more workers in, and it became really competitive in the marketplace. So if you wanted to get a raise to somebody, there was a raise freeze, and basically they were taxing any increases at 90%. So if you were giving an employee a raise to bring him from another company, that was taxed at 90%. So in the market, they came up with an idea through the government that we're going to let you take the individual plans and run them through as pre-tax. The insurance companies came in and said, well, if we're going to do that, why don't we just put one plan in place for your whole company? and then you can run that through pre-tax, et cetera. And that's basically where group health insurance came into play. That was only supposed to last about 2 years. That was in 19, I think, was it 41 or 42, Tom, something like that year? Well, here we are in 2013, it's still in place. But what we've seen as an industry and as an agency, 30% of our group business over the last 5 years has went to the individual market. The statistics that they're looking at, by 2018, 70% of companies that have 500 or less employees will be dropping their group health insurance plans and opting into individual health insurance. So you're going to see a big swing from the group into the individual market. What's the reasons for that? Like Mike mentioned, it's guaranteed issue. They're no longer going to be underwriting by health conditions, so everybody can get health insurance. They're going to have subsidies and tax credits that's going to be available for people to purchase their own individual health insurance plans. So, moving forward, that's basically, what we're seeing the direction as it's going. So for individual health right now, you have 3 options, really. One, you go uninsured, which, as you've seen the numbers out there, they're skewed all over the place, but there are several millions of people that are uninsured right now, whether it's their decision or whether they just can't get insurance. The other option, option 2, would be to secure an individual health plan through an exchange. And I'll go through an exchange in a little bit greater detail in here in a minute. And then the third option is to secure insurance from your employer. Those are really the 3 options for you to get health insurance. So option 1, we don't want to talk about. But if you do elect and you don't have health insurance, you pay the tax that goes in. So they're not calling it actually a penalty, but we do because it is written in a lot of different places. But basically, in 2014, if you do not carry health insurance and you get ready to do your taxes at the end of the year, it's going to be on there, you're going to pay 1% of your taxable income is going to be in a penalty that's going to be coming out of your tax returns. Basically the way it's going to be. 2015, it goes to 325 or greater of 2%. So as you can see, going up the ladder, there's going to be higher, stiffer penalties for not carrying health insurance. So that's basically how it's going to work, and it's going to come right out of your tax return. And if you don't have a tax return, then they're going to take it out some other kind of way through that. It might be on where we're seeing now that they're going to add it into your adjusted gross income. So you're paid taxes one way or another on that if you do not carry health insurance. Reverting back to option 2 is the exchanges, to go out and purchase your own individual health insurance plan. And this is where we see where there's going to be a lot of companies that are going to revert back to the old model of just providing maybe some types of monies that Tom's going to talk about through the group product, but going in and giving people money for their health insurance to go out and get their own insurance on their own. So there's 2 exchanges. There's a federal exchange and a private exchange. An exchange, or as you might have heard also, the marketplace, it's nothing more than a place to go out and purchase health insurance. So right now, we have an exchange out there. We have a private exchange. We always have. And that's going out and working with us to get an individual policy through Blue Cross Blue Shield, Humana, UnitedHealthCare, PHP, etc. All the different carriers that we work with, which, by the way, as Tom wanted me to allude to, that I forgot in the beginning, we're contracted with every insurance company in the state of Indiana and in multiple states right now. We're in 9 states. So we try to carry all those different contracts with all these different carriers to make sure that we can provide coverage for the different needs of individual clients. But that's what the exchanges are. If you want to go into the federal exchange, there's going to be different levels. So from 133% of the poverty level to 200%, they're estimating that that's going to be about 40% of the population is going to fall within that range. Between 200 and 250% of the poverty level, about 25%. And then to get the tax credits, which is 250 to 300%, about 15%, and then up to the 300 to 400, we're looking at 20%. That's where you're going to get your subsidies or your tax credits. And we got a couple examples that I'm going to have Chris go through in just a minute to kind of show you how those formulas work and how it's going to be based on your income. Like Mike alluded to, it's no longer going to be about your health conditions. It's going to be about your age, demographics, and your income. The private exchange, or for the federal exchange, the guidelines say in Indiana there has to be 3 carriers in that federal exchange, minimum of 3. One of them has to be a non-for-profit company. Right now they did the filings May 1st for here in Indiana. The only company that we're aware of right now that's publicly released that they're going to be in exchange is Anthem Blue Cross Blue Shield. There's still a couple other companies out there that just hasn't released that information publicly to say whether or not they have filed or not. So as soon as we get that information, we'll be able to post that and provide you with that information. But on the private exchange, as you can see, you'll have United Healthcare, Anthem, Medical Mutual, Humana, Celtic. There's Assurant Health. There's multiple companies that's going to come into the marketplace on this private exchange. The private exchange is basically anybody can buy through the private exchange. But if you're 400% or less in the poverty level, that's where you'd want to look at the federal exchange because you're going to get subsidized on your premiums.
Who's going to subsidize that? The government?
The government is.
How are they going to do that through your taxes?
It's going to be based on your household income. So on your tax return, and we're going to go through that in just a minute, Willie, to kind of show you the examples on how that works. But basically, just to kind of give you an idea, healthcare reform, here's your rating areas just in Indiana. This was just released within the last couple weeks. You can see the different areas, especially like the one up here, which is Fort Wayne or Allen County, that has its own rating area. But if you look at the green surrounding where we're at in Angola, going down in even into Adams and DeKalb County, so based on where you live is where your premiums are going to be, and that's where your subsidy is going to be. So it doesn't matter where you work. If you don't have a group plan and you're an individual, it doesn't matter if your employer is providing with you some type of income or some type of subsidy to go out and get your own health insurance. It's where you live is where you're going to pay. And that's just one state. We've seen other states that have similar models that have as many as 30 to 40 different areas. Yeah, it's where you reside for your individual health plans. Now, if you're on a group plan, it still goes by where your employer is. But as an individual, it's going to be based on where you actually live, your physical address. Next slide. With a federal exchange, this gives you an idea of the poverty levels. So anything under 133% is your Medicaid. And you've probably heard or maybe seen on the news there's several states that opt out. So previous, if you were 100% of the poverty level or less, that's when you qualified for Medicaid. So there was a gap that was left between 100 and that 133%, that there was absolutely no funding out there for anybody. So that's where the states opted and say, okay, we're going to extend our Medicaid to that 133%, so now folks can get subsidy. So if you are at 133% to like 150%, it states that you cannot pay more than 3 to 4% of your household income for health insurance. Goes all the way down to where the maximum is at 9.5%. The poverty level is going to be based by demographic areas, and we have a slide that we're going to go through. It's kind of going to show you a little bit, but the poverty levels are going to vary. The poverty level in Indianapolis is not going to be the same as the poverty level, for instance, maybe in South Bend. There could be a little variance there. So they're going to publicly put those poverty levels out and where the numbers are, and there'll be charts that you'll go through and stuff. And that's what we're here for, quite honestly. Our agency is going to have all that information, and that's where you're going to get on the phone and call me up and say, Scott, I need help finding the right plan, help me get enrolled, where am I in the poverty level, etc. That's when you're going to go through us and our navigator system that we have set up in our call center. Okay? But that's basically how the model is set up. So that's for individual health insurance. What you're going to see on, though, is people are going to say, you know what, don't give me a raise, because if you give me a raise, I go up and I'm going to lose quite a bit of money on my subsidy now for my health insurance. They've already said it's going to be a trend out there. So, you know, we get a lot of questions from the employers. How's this going to affect me? I don't have 50 employees. I have less than 50. It's not going to affect me. It's going to affect every single person in this room. Everybody. And just kind of give you a little feedback on that. Car insurance. Does anybody remember when car insurance was made a law? It was varied by states. The first law was passed in Connecticut in 1927 that mandated it was a law to have car insurance to get your license. All the way up to Wisconsin, I think was the last state, wasn't it, Chris, in 2010. So you're going to see, you know, there's going to be a lot of changes in there. And, you know, over the next few years, it is going to happen. I mean, they're not going to go back and they're not going to take healthcare reform out. It's going to be here. So we just kind of have to adjust and adapt to it the best we can as the mandates and things are presented to us. So let's go to the next slide. There's the poverty level you were asking about. So basically, looking on this slide, and you have it on your sheet there, if you're a family of 4 And let's say that you're right here at 47,000, you're at 200% of that poverty level. That's going to distinguish where you actually fit in the exchange. Like Mike was alluding to, you have the 60, 70, 80, 90% on that federal exchange. Your income and your plan designs are going to be based on the second lowest cost of the silver plan. That's where the government has set the standards for individual health insurance. The second lowest plan on the silver is what they're going to base your subsidy off of. So you might be able to get subsidized maybe 50% of your premium, but if you want to buy up in the exchange, you can do that. So you're going to have folks that might say, well, my insurance now that I'm paying is going to be $300 a month, but because of my income, it's going to go down to $110 a month, but I can still afford $200, so I'm going to buy up and go from the silver plan to the gold plan. There's going to be a lot of options out there. Once again, where are you going to go to get that information? PMG. So that's kind of how the federal poverty levels work. And it's going to be, like I said, it's going to vary. And they'll provide us with that chart, and then we'll be able to direct folks into the different plans. We've already been told that they're working with the government, basically, and they're going to take those estimates, and they're going to send that tax credit to the actual carriers. And it's going to be basically kind of like for the Medicare, for the Medicare Advantage plans, which is kind of complicated way they have it set up, but you get credits in there. So basically, let's say that, for instance, he's going to get $350 a month tax credit or equivalency. He sends in his information based on his W-2 from last year, his tax filings from last year, and it puts it through. The government's going to estimate that, and they're going to send in information, let's say Anthem Blue Cross Blue Shield. So now you go get your plan, and Anthem's going to say, okay, the estimated tax credit is going to be this is what your premium is. So at the end of the year, there might be a variance on there. It could be by people changing jobs, or like we talked about with increases in pay, etc. There could be some adjustments at the end of the year. There's no question about that. But there is no exact way to pinpoint it for every single person.
You have two options. If you're 49 or fewer or less employees, option one is you stay where you're at. You continue to offer group health insurance. Okay. Good morning. Okay. Thank you. Now, there's some things obviously we got to consider. We have the taxes that are going to be applied to our group health insurance, all insurance. And there's a couple different taxes that are applied directly to the carrier. There's taxes that are going to be applied to the vendors that we work with as health insurance care. There is the band, which Mike talks about, the pricing grid, how it went from 700% down to 300%. There's the mandates of healthcare being provided with lower deductibles and essential benefits being applied. All this is going to drive your cost of your healthcare up. So they have released to us they haven't released any pricing, but they have shared with us so that we can expect a minimum of 35% increase on your renewal on 2014. Let me restate that. That's additional 35%. So if I deliver a 10% renewal, it's 45. If I deliver 20%, it goes up, based on all the mandates that we're being pushed at. Now, that can vary a little bit in a couple of things. One is grandfather clause can make a difference, and also it can vary a lot on the census. As we alluded to earlier, young males are going to pay a lot more. So you may see where you have a group that's older and already has a rich plan, that price maybe even come down. But most likely, everybody's going to go up an average 35%. Anthem's done study with some groups that are primarily males, and they had a 100% increase. So option one is to continue to do what we're doing, and we'll, on your 2014, you can expect those changes. Also, if you continue to do what we're doing, you have to have the qualified health plan, so I already mentioned that with the additional costs. You also have to offer the scheduled benefits of coverage. Your administrator of your group plan is required by the federal law to mandate that they provide this to your employees. We do that. We're in front of that as our agency. If you may have worked with me in the past, and I already gave you the scheduled benefit coverage. We also have it available to you in our web-based platform for our clients. But it is worth mentioning, if you don't do these, if you don't offer the W-2 reporting for those over 250 W-2s in a calendar year, there's penalties involved. And they can vary from $1,000 to $2,000 per employee and an additional $100 to $300 per day. And then the last one worth mentioning is you can't exceed 9.5% of the employee's gross pay for their health insurance. Now, I want to be clear, that's the employee's health insurance and it's the employee's pay, not household at this point, and not covering your family, but the employee. This was not a factor. But if I move, if we can go next slide, if I move your premiums up, it's going to become a factor. Let me restate that. I have nothing to do with raising your premiums. You guys got me believing I do, the way you talk to me all the time. This shows you from 1999 to 2011 how the pricing has changed, being orange being single and black or dark being family coverage. Not a shock. We all know this has occurred as we've gone through this system. But 2011, you have $54.29 for the family for a single premium. What is it going to be in 2014? $7,500, $8,000, $650 a month for an average. And if I'm doing a payroll deduction, Willie, you mentioned 50%. Now 50% of $650. And based on my income, let's say I make $30,000, my maximum tolerance of 9.5% of $30,000 annual income is $54 a week. Well, we could very well have an issue. And what happens is when an employee goes to the exchange because you're in violation, go back one slide please, you're in violation, particularly this one where it would happen, then you get audited. Because through the process of us enrolling employees or enrolling individuals, part of the process is where do you work and what health coverage you have. If your coverage is not a qualified health plan, then that's how they're going to come back and get, the IRS is going to come back to you as owners of the company and fine you those fines.
And that is a $3,000 fine.
Yeah, and it varies a little bit with each one. So let's go ahead and move forward again, and one more time. So then option 2, as you mentioned, is how we do a defined contribution. How can an employer help? So Scott spoke on the exchanges and how as an employee or how an individual can purchase and is guaranteed issued and get subsidy for the exchanges and how that cost can be driven quite low based on one household income. So we have the health reimbursement arrangement. So you may be familiar with that term, health reimbursement arrangement. Typically that was to pay claims. Through a defined contribution, it's a business expense and account for health care. So we're taking the health reimbursement account and a claim is now going to be premium. So when we refer moving forward, and we're using a different section. So health reimbursement account is maybe an umbrella, and then inside or below that umbrella, there's different filings and sections that we file. So this may be a little bit different. This was passed in 2007, effective 2009. It allows us for individual health insurance, allows us to do this. So the business determines the eligibility rules. This can vary greatly. Unlike with your group health insurance, whatever you do for one, you typically must do for all. There's very little variances to that. Hope you don't mind Willie. Willie pays 50% of his premium, as mentioned. He pays 50% of his premiums for all his full-time employees that elect to have health coverage. Here, using this model, we can determine that eligibility based on many other factors, as long as it's bona fide, is the word they used, lawyers used, and if it's in your filing cabinet. So I would like to take my salary engineers and give them $700 every month towards their health insurance. I like to take my hourly employees, for example, and give them $300. I like to take owners and give them $1,000. These are all just examples how you can change that structure under this plan, unlike your group. The employer incurs the expense of the submitted claims. So I have to submit my claims as an employee, and then you would pay them. A claim is premiums, and you're going to pay them according to the eligibility rules that you have defined. So Scott's claim for him after subsidy is $600. You as an employer are providing $300. So he's going to capture that $300 to pay for his health insurance through the exchanges, the plan he picked. Mine is $200. I have a lower income. I have higher subsidy. I only need $200, but I cannot exceed my premium. So you're offering $3, but I can capture $2. And then this is done through our partner, Zane Benefits. And they'll keep it compliant as IRS, as Department of Labor, HIPAA, and then you'll be reimbursing tax-free approved expenses. But under the section 103, I better read it, 106BA3, we'll find it here in a second. That was a law that was passed in 2007, went into effect from 2009, again under this umbrella that I refer to in my mind anyway, which allows us to take individual premiums and pass them through. Scott alluded to it earlier. I have clients that write $30,000 every month for health insurance, a check. That money is passing through tax-free. We move out of the group plan. You don't offer group health insurance. Even if you don't want to do a defined contribution, you're not going to offer your employees any money towards their health plan. You still want to do this. You still want to do this because you want your employees to pass that premium through tax-free. So again, we're going through the two options, one of them being your group health insurance, and two is using the exchange products, being federal or private, and then using the health reimbursement with the defined contribution. Okay, now we're ready. Summary, HRA defined contribution overview. You determine the employer. As you can see, you set the eligibility, you pick the start date. You direct your employees to the PMG advisor, which is important for us because for us to put them into your HRA, we have to be their agent. You'll reimburse employees for claims. Again, claims we refer to as premiums. And then the employee, they enroll through exchange using the call center. They're going to receive the explanation of benefits or the actual policy and plan design as they chose. They're going to receive a welcome kit from Zane. Benefits, this is how to file a claim. So every month they're going to actually do the software to file the claim. And that can be done most likely online, but it can also be done by phone.
Faxing as well too.
And fax. Mm-hmm. And PMG agency office support. This is very simple, what we're doing. But I'm going to tell you, my experience of just life and my experience of dealing with this moving forward, it is not simple because it's new to me. And when it's new, it becomes confusing. It really is simple, but we have the office support to make sure that not only you with webinars, not seminars necessarily, but webinars, you understand your process through this, working with Zane Benefits, and then our process back to your employees and making sure that they understand what they're doing with exchanges and how the subsidies and the products work. Right. If they go to 1-800-OBAMA free health insurance or through the federal government and buy their health insurance, and you're going to see your employees, you're going to see TV and radio advertising, we were told, this fall saying it's open enrollment. We are noted as a web broker. It's a new name for me, I'm sorry. Just got told this last week. But we offer all the exchanges. So not only, wouldn't it be uncommon that an agent goes through the process and be filing and trained to sell Anthem, Blue Cross, Blue Shield through the private exchange? Well, we offer all of them. And if you go on our website today, you put that information, you get all the carriers just drop in with pricing on the individual side. Then we're also going to be on the exchange side with the federal government, so we can work with them with the poverty levels and know what their subsidy. So at the end of the day, we're going to find the best product. It doesn't make a difference what product they purchase, but once it's purchased, they know how to use the software to get the claims process. So then you can add your defined contribution and it all triggers. And if it's PayServ or if it's QuickBooks, it doesn't make a difference. It's just that easy. It will work. But there is a training side that you have to go through using Zane Benefits, another webinar, to go through that process so you have a clear understanding. So that, again, going right back here, this is a big piece of who we are. It's not just a piece of paper. Go next slide. I want to mention too, and I don't think this is on a slide, but you're going to have this open enrollment, and it's going to be announced here this fall for a January 1st effective date. And then you're going to have another enrollment starting in late December for March 1st effective date, I believe, Scott?
It's first and following month after December 16th.
Okay. So you, as your employees in your company, you most likely are not going to run out and go, Tom, I want to get this done now. You're going to want to do that evaluation when I come in, or we come in and do your renewal. And I would hope, even though most people in this room I know, I would hope if we don't manage your group health insurance currently, this is the reason, this is the argument I'm asking and making and asking for your business, because on your renewal is when the decision is going to be made, what's going to work best. And there's going to be many factors that are going to come in play. One is obviously the costs. And then we talked a lot about how that can come in play. And two, also, what is your needs? It wouldn't be uncommon, I would think, that the companies with very high incomes will keep in a group, even a small group, because of retention and recruiting. That's kind of typical. But on 2014, if your renewal is February 1st or December 1st, that's when we're going to do the evaluation. That's when we're going to say, no, we're moving to the exchange, or we're going to continue off with the group health insurance. Defined contribution regulations. Defined contribution claims are reimbursed under Code Section 106C2. My God, why can't I remember that? An employee's dental, vision, medical, and other qualified premiums are sheltered from taxes under the Code Section 125. And next, and I believe, one more. Benefits of defined contribution HR reimbursement arrangements versus group insurance. Okay, it seems to me we're going to use a defined contribution when you look at this simple chart, because the HRE, you have no minimum contributions, you have no minimum participation, and you really have no minimum households administrating. And it's just the opposite in the group. You are required to have participation. You are required to pay the premiums. And certainly you, as anybody knows in this room who manages the group health insurance, there's a lot of questions and administration work that's involved in the group plan. Let me say this one more time, though. This may not be you. You may stay here based on your renewal when we provide that information to you at that time. Blue Cross Blue Shield has announced that they're trying to move everybody's renewal to December 1st, 2014. So if you had a renewal here coming up in August, it's going to be pushed back, or if you had a renewal in January, it's going to be pushed out to 11 months. The idea is that we can just miss at least 11 months of this and renew then make that decision. Medical Mutual also made that same announcement. And the details moving forward, nothing's been released, but they will be timely. So, very good. And Scott?
For most employers, health insurance becomes sometimes the second or third largest expense that they have. With these opportunities now, with the exchanges and some of the reimbursements and things going on, it's going to give employers an opportunity to get out of the health insurance business, basically. And that's where we're going to be able to come in and assist with that. You should be able to concentrate on your business and not worry about, like Tom said, your 30, 40, 50% increases every year, and turning around and telling your employees, well, we got to go from a $2,000 deductible to a $3,000 now to keep your premium, etc. Those we've seen in the past are going to kind of revert towards the individual market. That's why I was talking about before, saying that companies that have 500 or less employees, you're going to see 60% of those companies dropping their health insurance in the next 3 to 4 years. because they're going to get out. They're going to say, you know what, I can be better off to manage that and put that budget in as an employee. I'm going to give this amount of money, health insurance. This person's going to get this amount of money, like Tom said. You can class that out. You can class it out by seniority, by different classes of salary versus hourly, etc. So there's a lot of different things you can do. The one thing I want to allude to, though, that Eric mentioned at the beginning, these reports we receive clients, they're great reports. And Willie, you were asking a couple questions about the exchanges. This report that we have, if the employer is to release this information to us as PMG, I know where their salaries are at. I can turn around and I can tell them basically what is going to be the best and where their exchange is going to be and what going to be. You're not going to find that out in the open market by or one of these other companies out there. And we get calls every day from well, you know, online, you know, 6 months ago, and I just found out I'm paying way because it is anybody to do it on their own, you know. You don't just go on. I mean, you get I mean, this is very important. Oh, if your car insurance is out there, your car insurance is paying for your windshield wipers, your brakes, your tires, your oil changes, etc. It's there in case you have something major to your vehicle. And health insurance has kind of gone that direction where you're seeing more of the major medical portion of it, the catastrophic coverage out there. And you know, so now with this healthcare reform, you're going to have the options of looking at different plans. You're going to have to know where to go. And look at those options. You're going to have to know, you know, what this, you know, as far as the exchange and the tax credits and you know, the tax filings and what do I use and stuff. And like Tom said, that's going to be able to help. But once again, Todd and I have been working together for many years, and we started talking about these different reports and what would be valuable for us and for his clients.